Okay, so hi, I think you've got hello, hello. I feel like I'm in a concert. Anyway, so you had like a 2 minute break in between. Now let's start. So welcome everybody. Psychiatry lecture series are going on, and I'm Dr. Swaleha. Today we are going to discuss mood disorders. I think all of you are in mania today. So that is why today's mood disorder is probably a good topic to learn. So mood disorders are also called as bipolar disorders, and we'll see why. But the bipolar mood disorders will tackle this big topic in two parts. First part today, which we are going to cover, is the classification. Second, we'll also just see the clinical features. Clinical features will divide again into two, mania and depression. So mania and depression, these are the two poles of bipolar mood disorder. So that is why the name bipolar comes from the two poles. These are two opposite poles, and like one of my professors used to say that this is a disorder in which there's kabhi khushi, kabhi gum. So gum is your depression and khushi is your mania. So these are the two poles. Uh, Etiology and treatment will cover in the next lecture because it's a very big topic. So let's start with the classification. Just like all other illnesses, psychiatric illnesses, we use International Classification of Diseases, ICD-10, and according to ICD, bipolar mood disorders are classified into manic episode, depressive episode. So these are the two main poles that we can see. Bipolar affective or mood disorder is when you have either a manic episode with depression or two or more manic episodes. So basically when two or more episodes start occurring, we classify it as bipolar mood disorder. Then the patient can have repeatedly depressive episodes, so it is called as recurrent depression. Sometimes it goes on for a very long time, so it is called as a persistent mood disorder or cyclothymia or dysthymia. I know these are words which are not very familiar to you, but just try to keep up, and we'll discuss these in details later on. And then there can be other mood disorders also, but main are your manic episode and depressive episode. So let us first look at manic episode. How will you diagnose it? What are the clinical features which are seen? The most important clinical features which should be present in all patients is a change in mood. It is a mood disorder, so obviously we need some changes in the mood. The mood can be elevated, expansive, or irritable. So as you can see in this diagram, normal mood is called as euthymic. So normal mood can either go into irritability when the patient starts getting very angry over trivial issues, or patient can be very happy, and this happiness is seen in the form of expansive or elevated mood. Now this elevated mood, according to the severity, we can classify it as a euphoria. Elation is a little bit moderate elevation of mood. Exaltation is again very happy, very severe happiness in the mood is seen, and ecstasy is just beyond happiness. So these are the types of mood changes you can see in a patient. Apart from mood, there are changes in psychomotor activity. So activity of the patient is increased. Okay, so activity is increased means patient will be either doing walking or running or dancing. Can I help you, sir? Oh, sure. Please let him sit. Okay. Everybody is comfortable now. Okay. So again, increased activity can be seen in the form of a lot of things that the patient keeps doing. So patient will be walking, running, dancing inside the ward. So there is increased activity, and this activity, just keep in mind that it is a goal directed activity. So whatever activity that patient is doing is usually directed towards one goal. So you can see that the patient is doing a lot of work, a lot of output is seen by the patient. Then comes your speech and thought. So the patient is more talkative than usual. I know a lot of us like to talk a lot, or a lot of us are very social. That does not mean you have mania. More talkative than usual. So whatever is the normal for that patient, a little more than normal is called as increased talkativeness. Patient can have racing thoughts in the mind. The language is very playful. There can be a lot of jokes, a lot of teasing. They might maybe speak loudly. They might start singing also. Like if any of you have come for clinical posting in our ward, one patient is definitely singing in the ward. So you know that is the mania patient that is singing. Then this is a very interesting phenomena which is seen only in mania or a manic episode. This is called as flight of ideas. So in this diagram, you can see a flight of stairs. So that is how they've described this flight of ideas. You can see that the stairs are connected to each other. So that is how the patient's speech is. The words or the sentences are connected to each other. The patient will be talking very fast, very loudly, and there will be shifts from one topic to the other. And the patient will use some external cues or some rhyming, some punning, but there will definitely be a connection between these sentences. Sometimes, when the flight is very severe or the patient is very symptomatic, incoherent speech can occur. But mostly, the speech which the patient says, you can make it out, and there is a connection between these flight of ideas, or a connection between the ideas can be seen. Now comes grandiosity. So grandiosity means a kitten feels that it's a lion. That's what grandiosity is. So we can have a patient who's probably a very poor farmer or a laborer, but he feels that he has property worth crores. He feels that he might know the Prime Minister of India. Or we had a patient who felt that he had godlike powers or superpowers. So again, this is what we called as grandiosity or inflated self-esteem. Patient can be seen more social than usual also. And if you have superpowers, then you go into risk-taking behaviors. So risk-taking behavior will be buying sprees. So patient might be earning just 10,000 rupees a month, but they'll buy watches worth lakhs, or they'll buy a lot of properties, take a lot of loan or a lot of money from people. They might get into reckless driving, thinking that they are invincible. There can be a lot of investments which are very bad, or they might just give away their money, their jewelry to strangers on the road just wanting to help them. So these are all symptoms of grandiosity, symptoms of a manic episode. Now, what is this short form that we are going to use? I've told you a few clinical features of mania. I've bombarded with you with a lot of information. Just to remember the symptoms, we have a mnemonic which is dig fast. So D is your distractibility. That is, the patient is very distractible, cannot focus at one place. I is your impulsive and reckless behavior. G is grandiosity. F is flight of ideas. A is increased activity or goal directed activity. S is sleep deficit. So patient will be sleeping probably just 2 or 3 hours every night, but will be very refreshed, very energetic, will not feel the need to sleep at all. And then T is your talkativeness. So these are the symptoms of mania. This is the summary of what manic symptoms can feel like. Now, sometimes I know you do a lot of work, especially when you have not done and the deadline is there. You do work, or sometimes you feel very happy, but that does not mean that you have a manic episode or you're suffering from mania. You need at least 3 or 4 of these symptoms for more than 1 week. Feeling happy for a few hours is not mania, okay? But if it continues beyond normalcy for more than a week and these symptoms are present, then definitely we can think about diagnosing the patient with a manic episode. Okay, so now let us go to the next opposite spectrum of bipolarity, that is depression. Now, I know depression, you guys at least must be having some or the other idea because depression has gained a lot of popularity. People know a lot of symptoms of depression. But as doctors, clinically, you should know how to make a proper diagnosis, an ICD diagnosis of depression. So, the most common symptom which is seen is depressed mood. So, there is sadness or low mood, and again, feeling sad after watching a sad movie or having situational sadness is again normal. But if this sadness is persistent, pervasive, not going away, then or out of the normalcy, then we say it as a depressed mood. Then, um, after depressed mood, what we see is loss of interest or loss of pleasure in previously pleasurable activities. This is known as anhedonia, or which is usually again seen in depression. So patients will tell you that I used to like listening to music, I used to like going out with my friends, that used to bring happiness to me, but now I've just lost interest, or I don't get pleasure out of these activities which I used to enjoy. So this is technically or clinically known as anhedonia. So two main symptoms, depressed mood and anhedonia, are seen in depression. This is what we have discussed. And in severe depression, there may be complete anhedonia. That is, there is no pleasure. Like whatever the patient says or does not feel pleasurable at all. So this is again a symptom of very severe depression, but very, very commonly seen in most parts of depression. Now, depressive ideation. This is again a thought disorder. So there are some abnormalities in the thought process. These depressive cognitions are the triad which was given by Aaron T. Beck basically. And what this triad consists of is hopelessness, helplessness, and worthlessness. So sometimes an MCQ may be asked in your exam about the triad of depression. So hopelessness, as the name suggests, that the patient feels there is no hope in the future. Future is very dark or future is very bleak. Helplessness means nobody can help me. They feel that the situation is such that however great the person is, nobody can help me. Worthlessness is again basically inferiority. They feel that I am worth nothing. And these are again very pessimistic thoughts which come very commonly in depressed patients, and these are classified under depressive ideation or cognition. Now, psychomotor activity in manic episode was increased. So, the polar opposite in depression, psychomotor activity will be low or it will be decreased. So, in younger patients, the psychomotor retardation is very common. So, people who were previously very active, probably working, will stop working. Sometimes even their thought process is slowed down. Patient feels that there's no energy. They feel very lethargic, or they might come to you saying that, doctor, I have a lot of weakness. I have no energy in my body. Even their way of speaking, their tone will be very monotonous. So these are all symptoms of psychomotor retardation. If it becomes very severe, patient can even become stuporous. This is called as a depressive stupor, in which the patient stops reacting to the external environment. Patient will not be moving at all. So this is the severest form of psychomotor retardation, which is seen in depression. Now, another set of symptoms seen in depression is called as somatic syndrome. Soma means body. Now, most symptoms in psychiatry are at the level of thought, or what we can classify it as a psychological symptom. But this somatic syndrome will have bodily functions or bodily disturbances which is seen. So there is decrease in appetite, and the appetite must be so low that there is a significant weight loss also. So patients will come to us saying that their clothes have become loose, or they've lost some 5-10 kg over a period of 3 months. So the decreased appetite is not just psychological, but there is actually change in weight which is seen. Then early morning awakening. This is a very, very pathognomic symptom of depression. Patient will come to you and say that I used to get up at 6 o'clock, but now 4 o'clock I just get up and I'm not able to go back to sleep, and I just don't feel the need to sleep at all. So early morning awakening at least 2 hours before the usual time of awakening is seen in depression. Diurnal variation is seen. Again, depression is worse in the morning. This is usually related to the cortisol levels, because again in depression there is abnormality in cortisol levels, and this leads to worsening of the symptoms in the morning. Then there is loss of interest, loss of reactivity to pleasurable stimulus, and then psychomotor retardation. So all these 5 symptoms are classified as somatic syndrome in depression according to ICD. So again, this can be asked either as a MCQ, or they can just tell you to just list the somatic syndromes that is seen in depression. Now, just like we had made a mnemonic for bipolarity or a manic episode, we have a mnemonic for depression also, so that all the symptoms can be easily remembered. D is your depressed mood, obviously. E is loss of energy or fatigue or generalized weakness. P is loss of pleasure. R is your psychomotor retardation or the decrease in physical activity which is seen. E is your changes in eating. S is sleep. The second S is suicide, which is very, very important, which we'll see in the next slide. And I is basically a loss of confidence, or the thought that I'm a failure, the ideas of hopelessness, helplessness, and worthlessness. So this is the mnemonic for depression. Now the last important thing to remember is suicide risk. Okay, suicide is one of the only emergencies, the only red flags in psychiatry which we've seen, and it should be taken very, very seriously. Now, a very common myth is that if you ask a patient about suicide, the chances of suicide increases. Is this correct or wrong? This is wrong. If you ask a patient about suicide, the chances of suicide do not increase. Please, please, please ask the patient or your friends, whoever you feel is depressed or might be having suicidal ideations. Asking them about suicide will not increase the risk. Suicide is nothing but a cry for help. They want somebody to help them. If you ask them about the suicide, risk will always go down. So, suicidal risk is there in a particular symptoms or a particular demographic of patient. So if the patient tells you that they have hopelessness, then the chances of suicide or the suicidal ideations definitely are more. So if the patient tells you, I'm feeling hopeless, please ask them about suicidal ideations. Then males, suicide is much more common. Age more than 40, unmarried or divorced or widowed. So marriage is supposed to actually protect against suicidal risk. Then any type of written or verbal communication. So if somebody is writing a suicidal letter or a will or something which is written by the patient which might give you an idea that there is a suicidal plan or an intent, again it is very very important to ask them about suicide. Early stages of depression, suicidal attempts are seen more. So again, if as psychiatrists we feel that the patient is in the early stages, we definitely ask the patient about any suicidal ideation. Now, the opposite of early stage is recovering from depression. So at the two extreme ends, the risk is more. So what happens is when you give some antidepressants or when the patient is recovering from depression, the depressive ideation is there, but the energy is more. So because of that increased energy, the risk for suicide increases. Before the patient wanted to commit suicide but did not have the energy. Unfortunately, towards the recovery part, energy increases. So again, a risk is more. Then period more than 3 months from recovery. So patients coming for follow-up in our OPD, we always ask if they have any suicidal ideations, and then of course we treat it accordingly. But these are the few risk factors which will give you an idea that patient might be suicidal. So always ask about the suicidal ideations, assess the suicidal risk in all patients, not just depressed, even manic episode puts the patient at risk for suicide. So bipolar mood disorder, very important. If you don't remember any symptom, please remember suicide, suicidal risk, and asking the patient about suicide. And if you feel that the patient has suicidal ideations, referring to a psychiatrist and starting treatment at the earliest is very, very important. It's an emergency. So this is the only emergency which we see in psychiatry. Very important, always keep in mind. And with this, we finish the symptoms and the clinical features part of it. So we have seen manic episode in which the mnemonic was dig fast. Okay, you can go through the full forms. And then we had seen the clinical features of depression. Again, a mnemonic was there, and then N, I. So I is always depressive ideations or cognitions are very important. So remember these symptoms. Manic symptoms should be present at least for 1 week minimum. It can go on for probably months also if not treated, but at least 1 week of symptoms. For depression, we need at least 2 weeks of symptoms. These are again the MCQs or the questions which they ask usually. So if you want to diagnose a patient with clinical depression, you need symptoms at least for 2 weeks, because feeling sad once or twice is fine, that is okay. But if there is persistent sadness for more than 2 weeks, then we make it as depression. If you have two or more of these symptoms, either manic episode or depressive episode, then we call it as a bipolar. Okay, so with this we finish the clinical features. Next lecture we'll see the etiology, the causes and treatment. But just go through the clinical features. If you have any doubts, just ask us. You can ask right now or later. But with this, we finish at least the first part, the clinical features part of bipolar mood disorders. Okay. So, any doubts? Anybody would like to ask any question? Share some anecdotes?